So good afternoon, everyone. We are just waiting for a few moments as all of our attendees log on. So we'll start presently. You're all very welcome to this afternoon's seminar. I'm Gráinne Healy, Chair of the Sláintecare Citizen and Staff Engagement Forum, and I'm delighted you've joined us for today's webinar, the 14th Sláintecare Integration Fund webinar, part of our Learning Network event series. We are taking questions during the broadcast, so if you're asking a question or making a comment, please do indicate who the question is for, and we will make sure to get the answers for you. The chat button for questions or comments is at the bottom of your screen, and if you type in a question or a comment, it will come straight here into us. We are very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Sláintecare is about providing right care in the right place at the right time by the right team. And in these webinars, you'll hear how projects funded by the Sláintecare Integration Funds and some HSE funded work are showing us best practice for healthcare reform and displaying how many have adapted work practices and created improved pathways while responding to COVID-19. Our theme this afternoon then is enhancing capacity and skills for the management of chronic conditions. Many Sláintecare Integration Fund projects are devising innovative and multi-stakeholder methods of supporting better management of chronic conditions. Some are initiatives involving training of professionals, others are supporting those with chronic conditions to better self-manage them. All of them are seeking ways to improve health outcomes for chronic disease sufferers. We have 3 Sláintecare funded projects for you this afternoon, but today we're starting first with a video by the HSE's South Dublin Community Intervention Team, who are engaged in a renal integrated care project, an initiative operated by the Community Intervention Team, who work with both Tallaght University Hospital and St James's Hospital, developing a virtual clinic and domiciliary assessment, bringing renal care and management of renal care into the community, especially suitable for frail or more vulnerable patients, leading to patient care at home and fewer hospital attendances. So let's hear now from the HSE's South Dublin Community Intervention Team and their partners about this really successful work supporting care of those with chronic renal conditions. The Community Intervention Team is a specialist nurse-led health professional team which provides a rapid and integrated response to the community, to patients who require enhanced services.
Díomhhuic agus fáilte. South Dublin Community Intervention Service is a nurse-led service delivering patient-centred care in the home and in the community. In May 2020, the Renal Integration Service and CIT developed a pathway of integration delivering patient-centred care in the home for the patient. This service was developed on a phase basis. The service was introduced to the team and the team took the project as a pilot project. Since the project's development, it has seen over 400 assessments with patients through James's. The service is now developed into the Telehealth Hospital.
My name is Brenda Griffin and I'm a nephrology consultant at St James's Hospital. I'm delighted to talk to you today about the collaboration between the Community Intervention Team and St James's Hospital Renal Department. The relationship began in March 2020. The initiative on our side came from Sue Paffreth, our wonderful renal CNS, who was a Northside CIT nurse herself. She was knocking on an open door and the CI team were really responsive. In the early days, Sue noticed patients who would benefit by having blood tests done in their own home and asked the CIT to do this on an ad hoc basis. In the very early days, the patient's relative either picked up labelled bottles or they were posted out to the patient's home and the filled bottles were returned by the volunteer bike courier. This evolved and there was a meeting in April 2020 in response to COVID and a pilot began in May 2020. And at that time, the blood bottles and the labels were couriered out to the CIT offices and couriered back. And the CIT nurses communicated blood pressure, weight, urinalysis, and Sue recorded it in the electronic patient record. This allowed us to keep patients safe at home and cocoon. It allowed us to provide a meaningful renal service. Our job is to retard the progression of chronic kidney disease and to treat complications. And by identifying anemia early or imminent pulmonary edema, we were able to address these and to avoid admission. On this slide, you can see some of the statistics. The Community Intervention Team have done more than 400 episodes for the renal department in St James's Hospital. When you consider that in 2019 there were 2,000 clinic episodes for the renal department, you can see what a contribution the CIT team have made. You can see that the patients come mostly from Dublin 8 and Dublin 12, as you'd expect, and you can see that the majority are men. This initiative has allowed us to maintain our capacity to see patients, to see new patients at a time when footfall in the hospital had to be reduced. In the future, we plan to book the blood tests in St James's Hospital and for the Community Intervention Team nurses to print labels in their own offices and then courier back the filled blood bottles. Using the electronic patient record remotely, the CIT nurses will be able to log weight, blood pressure, urinalysis directly into the electronic patient record in St James's Hospital under a CIT episode. This will reduce the risk of error and avoid duplication. The whole project has been a roaring success. For me, it's at the heart of what Sláintecare should mean, providing a seamless service to the patients we serve. And even though St James's Hospital is a tertiary referral centre, at its heart it's a community hospital serving the local community, staffed by the local community, and this project is a really good fit.
In March 2020, the government advised all over 70s to cocoon in response to the COVID-19 pandemic. This faced renal services at St James's Hospital with a conundrum as to how we were going to manage and monitor our patients, as a large group of our patients would be over 70. This pushed renal services to seek out community-based services to manage and monitor their patients in the community. Our request to the CIT was that they would travel to our patients in the home on a weekly basis to manage and to do bloods, blood pressure, weights and collect urine samples. So in May 2020, between CIT, St James's and renal services here, we launched a pilot service to monitor and manage our renal patients in the community. Since May 2020, CIT have carried out over 400 episodes or patient visits to the renal patients in St James's Hospital. Some patients are repeat visits and some patients are one-off visits. Helping to keep the patient at home keeps them safe, keeps them well, and can help manage and slow the progression of their kidney disease down. No renal consultation can effectively be carried out without a full suite of bloods, urine samples, blood pressures and weights. So the CIT, by visiting our patients in the home, have helped us to develop a virtual clinic to manage and monitor our patients in the community. The CIT have helped to avoid patients being admitted to hospital. For example, the diagnosis of fluid overload or impending pulmonary edema can be carried out and managed in the patient's home. They have also helped to facilitate the monitoring of patients with more advanced kidney disease who can be seen in a more timely manner face-to-face, and we can manage other patients in the community that don't need to come in.
Hi.
Hi, how are you?
I'm good actually.
Great, that's great. But you know what I'm going to do, the bloods and your weight and get the sample.
Yeah. My name is Ellie Keown. I've been with the service from the hospital since I was 73. I'm 76 this year. And I find nurses very helpful. The doctor very helpful. And nothing is too much trouble. They organise everything for me. I don't have to worry about getting to the hospital. And then when I went into the hospital about more heart surgery, and they were a bit worried then about the kidney, the renal crowd.
Yes.
So she said I might come down on
That's it?
what you call it, what you put you on.
Yeah.
I don't have to worry about getting to the hospital for to have the blood test done, which would be awkward because I don't have children living in Dublin, which means I have to either pay for a taxi or get somebody to bring me. This is what I'm on at the moment.
Yes.
Because I have it here.
Yes, 7, yeah.
Yeah.
But the thing is, at least you know you've taken them.
Yeah.
Yeah. You can't forget.
No.
Which is really good, isn't it? Yeah, that's good. So you've a good
I
relationship.
have it with you.
Yeah, with your pharmacist, yeah.
Yeah, he's very good. Because even the nurses go out of their way to be nice. I haven't met anybody rude, and all the time they're coming here. And I try not to be rude to them.
My name is Ciara Parthaban. I am the Tallaght University Hospital liaison nurse for the South Dublin Community Intervention Team. This pathway was developed with Professor Peter Lavin, consultant nephrologist, the renal clinical nurse specialists and the South Dublin Community Intervention Team. Our pathway provides our renal patients with a domiciliary assessment in order for them to have their outpatient appointment virtually. The patients who are identified for this pathway are those that are deemed as frail, vulnerable, and who would have difficulty getting back into their outpatient appointment. And this was all developed in response to the COVID-19 pandemic. This assessment comprises of the nurse taking the patient's clinical vital signs, a weight, a list of the patient's current medications, phlebotomy, and a urine sample. The urine sample and the bloods are then taken to Tallaght University Hospital labs where they are available on key, and the full assessment is then scanned and sent to Professor Peter Lavin and the renal clinical nurse specialists in time for the patient's virtual outpatient appointment.
Hello, my name is Peter Lavin. I'm a consultant nephrologist in Tallaght University Hospital. We have found that recently using the community intervention team has really improved the quality of our virtual outpatient consultations. We'd been doing increased number of virtual OPD appointments in the last 18 months to 2 years. However, initially we found that the quality of these did not match the face-to-face appointments. And we often had to do follow-up appointments very quickly because we didn't have all the information on the first occasion. Using the CIT team has really improved this, where a nurse visits the patient in their home, gets their vital signs, urines and bloods, and very importantly they get their medication reconciliation performed, and they give all of this information to us before the appointment. We found now that the patients are getting an almost equal service to those who attend in person, and the clinic appointment is very efficient with all of this additional information. So all in all, it has really enhanced the quality of these consultations.
Hello, my name is Bernine Laycock and I'm an Assistant Director of Nursing here in Tallaght University Hospital for Patient Flow. Our project has focused initially on renal patients. By testing this model on a small group of patients, we were able to determine its efficacy and also see how it can be applied to other patient groups with chronic disease. Tala University Hospital has a significant role in the health of our community, and we embody an ethos of a hospital without walls. The community intervention team has enabled us to deliver care in a patient's home that normally would have been delivered in hospital. This has avoided unnecessary hospital attendances. This collaborative approach allows us to provide an integrated service where both the acute and community wrap around the patient. As we move to expand this service to other patient groups, what is critical to the scalability and sustainability of our project is to continue to expand our access to the community intervention team.
So thanks to the HSC Community Intervention team there who put that video together for us. A great initiative fulfilling many of the Sláintecare characteristics, including bringing care closer to home, reducing footfall in acute hospitals, and supporting better self-management of those with chronic conditions. They've obviously had great success with their pilot for renal patients, and I think it will be interesting to see how other specialist teams linking with community intervention teams could replicate this model of new pathways of care for other chronic disease sufferers. Our first integrated funds project for you this afternoon is a telemedicine project working to improve care for those with cystic fibrosis. We met with the team earlier. Project today is telemedicine for cystic fibrosis. We have spoken about cystic fibrosis on these webinars before, and Ireland, as you know, has one of the highest rates in the world of this chronic disease. This project, Telemedicine for Cystic Fibrosis, aims to introduce physiotherapy-led airway clearance and exercise sessions delivered via telehealth to adults with cystic fibrosis, targeted at patients on home intravenous antibiotics and to those adults with cystic fibrosis who have commenced a course of oral antibiotics at home. The plan is that the telemedicine approach will deliver more optimal results with better adherence, improved lung function, and reduced exacerbations to the home patient cohort, but also facilitating early discharge and improved treatment when on IV therapy at home. I'm delighted to be joined by Irene Maguire, Senior Physiotherapist Project Lead, and Stephen Bradish, Senior Physiotherapist at Galway University Hospital. You are both very welcome. Thank you so much for joining us this afternoon. Irene, can I come to you first? Tell me a little bit about the project and the team, who you are and how you're delivering this person-centred care to cystic fibrosis patients.
Thank you, Gráinne. It's lovely to be here, and thanks very much for giving us the opportunity to share our project with everybody today. I suppose just as background, when I worked in Australia, I worked in a respiratory post-acute care service where I delivered pulmonary rehab to patients in their homes, and I was really struck by the difference in the person's confidence and their comfort when I came to their home to deliver services rather than when they came to me in the hospital. So I wanted to try and provide this kind of a service for our adults with cystic fibrosis in Galway. And when the opportunity arose to apply for the Sláintecare funding, I spoke with our physio managers and our CF consultant, and they were happy that I put in the application to do this in a telehealth setting, because given the size of our geographical region in Galway, for the wholesale region, and also the number of people with cystic fibrosis we provide services to, it wasn't going to be feasible to do it face-to-face, and it would be in a telehealth setting. So in order for it to be safe in a telehealth setting, as you've said, it was primarily geared towards patients who would be on home intravenous antibiotics or those on oral antibiotics. And so we wanted to ensure that we would have some way of monitoring our adults with CF. So we set up remote monitoring equipment, and we had to ensure obviously that not only the adults with cystic fibrosis, but also the team would have the correct video conferencing platform and the equipment to actually be able to both deliver or attend the sessions. So we set everybody up. We had our video conferencing in place. We had our remote monitoring in place. We have an escalation policy written. and we were ready just to start the physiotherapy service when COVID hit. So what was fantastic from our point of view was that because we had everything set up and ready to go, our CF multidisciplinary team were able to go overnight from face-to-face sessions to virtual sessions, which was something that was a very unforeseen but a very welcome bonus for our adults with CF. Right. So in our project team, obviously we have our CF physiotherapists, our physiotherapy manager, our cystic fibrosis consultant, and I suppose maybe more new and more very much welcomed members of the team are our IT consultants in the hospital, our IT managers, and also our clinical engineers who've been fantastic from a point of view of helping to support the remote monitoring equipment that we use. And obviously we link in with the rest of our CF multidisciplinary team.
Right. And how is it going? I mean, how is the project progressing? Are you managing to successfully provide the integrated care to the patients?
We are. The technology has held up really well, which has been wonderful. And again, obviously, we're always concerned about digital poverty, given the catchment area that we provide services to. But it's working very well. So technology is working well. And it is very much person-centered care insofar as we're delivering specialist care to our adults with cystic fibrosis in their own homes at a time that suits them. And the sessions are really geared towards the goals of our adults with CF. So they set the goals and they decide what the focus of the session will be.
So in that sense, you have this kind of co-design, co-progress with both the patients and the deliverers. Absolutely. Being able to monitor. And Stephen, if I can come to you, I mean, Irene mentioned they're all set up, ready to go, the great plans, COVID hits, need to pivot, need to change. Will you talk a little bit about that, about what did that mean in practice? What did you have to do differently when COVID hit?
Sure, thanks, Grania. Like Irene mentioned, we had everything ready to go when COVID hit. So essentially we were COVID ready. We had our we'd worked with our colleagues in IT and engineering, and we had the home monitoring set up and our portal ready to go to look at measurements. So just the benefit of having all this in place was we could expand it out to the wider CF team. And it meant there was no disruption to kind of any part of the CF service once COVID hit, and patients were able to attend their regular clinics virtually during lockdown. And they could speak to every member of the CF team, and as they would normally at a face-to-face clinic, and do the majority of their clinical measurements that they would normally do here in the acute hospital, but all from the comfort of their own home. So we're just in that very fortunate position that we, Sláintecare project was there. We were able to, extend the service out to patients during a very challenging, kind of anxious time for patients who have a chronic lung condition.
Yeah, and of course that point being really relevant, that any kind of infection for people with CF is such a worry and such a concern. And during COVID, I'm sure people were terrified at the idea of going into acute hospital settings and possibly picking up something that they were avoiding. So the telehealth model specifically for this cohort was I'm sure, a really kind of anxiety alleviating action. Talk a little bit, Stephen, to me, if you can, about the kind of outputs and impacts you're seeing from the project.
Sure. I think probably the biggest impact of the project was just increasing access to the physiotherapy service for patients with cystic fibrosis. So you think of the service, it's here situated in Galway City, but our geographical catchment area is huge. It covers Mayo, Sligo, Leitrim, all the way up to Donegal. And wow. For some patients, that's 6-hour round trip just to get to an appointment. So we reviewed the service after 12 months, and we saw an 11-fold increase in the number of physio outpatient appointments that we delivered via telehealth compared to the previous 12 months face-to-face appointments. Wow. That's a big increase with no DNAs, and I think that's an incredible achievement for any service. And we've seen a 13-fold increase in the average number of sessions that we've been able to deliver per patient over the course of that 12-month review. And we also saw a 58% increase in the number of adults who've chosen to access the physio service. So improving access has been like a major outcome of the project.
Excellent.
We looked at quality of life as well, Grania, and I think that's really important of any kind of project or service improvement. And we used 2 different quality of life outcome measures. And one of these measures was the CFQ UK quality of life score, and the average percentage improvement in this was 28%. And the other measure we used was a symptom score diary, and the average percentage improvement of this was 39%. So you can see, there's a positive impact on patients' quality of life. Probably part of this improvement, you could put it down to the fact that patients were saving time, they're saving money by accessing a service virtually, and the average travel time saved per patient over the first year was 29 hours. And for one patient, that was 213 hours, so huge time saving.
Huge.
Yeah, and then like cost-wise, patients saved on average €900 by not having to get in the car and come. So parking, petrol, all of those things. And for that patient who saved all the time, he managed to save himself €6,000. So
wow.
Lots
the
of
cost of a new second-hand car, maybe. I mean, it's a big savings. But what are the patients saying to you? I mean, are you talking to them and you're asking them? I mean, those quality of life indicators are really important, because at the end of the day, that's what it's about. It's about being able to live, a life as normal as you can, despite the fact of having a chronic condition. So what kind of things are they saying? Obviously, saving the money on the petrol is hugely important. I know, even talking to other people on the program here about, not having to fetch up to acute hospitals, drive, pay parking charges is a big one.
Yeah.
And also we mentioned the fear of maybe picking up cross infections. So are you talking to the patients? Are they coming back and telling you these things?
Yeah, absolutely. Well, we built kind of a, feedback mechanism into the project design. So Irene, along with some of the patients, they co-designed a bespoke patient experience survey, kind of a feedback survey. And I can give you kind of a snapshot of some of the things that they told us about the service.
Please.
Thankfully, it was hugely positive. They told us the technology was very easy to use that we gave them. They said the length of their sessions were about the right length of time, and they could follow instructions very easily over the telehealth platform. So that's important when you're doing kind of, intricate chest clearance or doing exercise and things like that. They told us that their physio airway clearance sessions were more effective and more focused with input from a physiotherapist, through the telehealth platform than if they were to do it on their own. So really, like 100% of patients said that, they'd like to see the service continue.
Right.
We got some really nice, like, kind of nuggets back just when we kind of offered patients, tell us in your own words what you think.
Hello, my name is Oisin Halligan. I'm a CF patient with the University Hospital Galway CF service. The telehealth or Zoom sessions really helped me after I started Caftrio to help capitalise on the improvement I got with it. These sessions also helped get my exercise tolerance to such a level that I'm able to go to college and live away from home. Without these Zoom sessions, I don't think I'd be in the position I am today. Thank you.
My name is James, and I've been participating in the telehealth sessions with Stephen and Damien for over a year now. I found it hugely helpful to maintain a good level of exercise weekly and ensure I maintain a certain amount of fitness. Sessions are great, tailored to my specific level, and can also vary depending on how well I'm feeling that particular day. Convenience is also an important part of the experience, not having to worry about traffic and parking while allowing me to do our sessions first thing in the morning, and also blending with my family and work commitments is really helpful. Stephen and Damien are terrific, and the whole service is really professional. I've seen a huge benefit in the programme and really look forward to continuing to be a part of it.
Hi, my name is Sarah Murray. I've been doing telehealth for 18 months and I do it twice a week. I enjoy it because there was a nice social aspect to it, and that there was a nice flow of conversation, which is nice, especially during lockdown. It has a huge benefit in my physical health also. I do feel fitter and stronger, and give me more energy in my day-to-day life. And it's also a nice way of staying in contact with the team and being able to discuss any queries. Thanks.
Patients are telling us it's really beneficial.
Yeah, and on foot of that, back to you, Irene. Is the model sustainable and transferable? What's next for telemedicine for cystic fibrosis?
Yeah, thanks, Grania. That's a good question, because we did wonder about sustainability, and obviously, a new service, and is it going to have a novelty factor that will wear off? And I suppose, testament to that, when things opened up more in the summer, people were still availing of the telehealth service, and even with people back to college, they're still availing of the service. So that's very heartening. I suppose, future for us now, we have started to extend this service to the children and adults and infants, or children and infants and adolescents who attend our service. And I'll be interested to see what further monitoring may well become available, like stethoscopes, which I know there are some there, but they're probably astronomically expensive just yet. Respiratory rate monitoring, that kind of idea, and how we can extend that into the home. And I suppose what's been lovely for us is that we now have a fully evaluated pilot project that we've been able to share with the National CF Clinical Programme, and it very much aligns with the future developments for care of people in Ireland with cystic fibrosis through the National Model of Care. So a lot of positives, I think, have come out. And I think the biggest thing that, one of the biggest concerns would be about safety of delivering a telehealth service to people with a chronic lung condition, and potential adverse effects, and how you would manage those. And like, we've thankfully had no adverse events, and we've put measures in place and escalation policies in place to make it safe. So I think for anybody out there who wanted to try it, I would say absolutely go ahead.
Go for it.
And as I say, our service design is something that can be lifted up and trialed anywhere else.
Elsewhere. Okay, look, it sounds like you've made great progress, and I'm sure the patients who've benefited have really benefited, particularly in COVID. But actually, I think by the sounds of it, it will go beyond that. So well done, great work. Irene and Stephen, thank you so much for joining us this afternoon, and best of luck with the rest of your work.
Thanks, Ronnie.
So another successful integrated fund initiative there, great patient testimonies, I think you'll agree, showing clearly the value of the telemedicine interventions, allowing people with cystic fibrosis on the programme to get on with their treatment while getting on with their lives, whether that's going to college or being able to return to work. So many thanks again to Irene and Stephen and the team. The second integrated funds project this afternoon is about treating childhood obesity through education. I spoke with members of the team behind this project earlier. Our second project to showcase for you today is called Facilitating Integration of Childhood Obesity Services in Primary Care through Education. This initiative is about building capacity in primary care for the management of child and adolescent obesity. Child and adolescent obesity can lead to serious health consequences during childhood and right into adulthood. In line with the UN Convention on the Rights of the Child, children should have access to treatment for health conditions, and providing treatment for obesity and related comorbidities is a key focus of Irish health policy since 2005. This project focuses on building capacity in primary care. It's closely aligned to many of the key aims of Sláintecare, improving training to improve the experience of service users, improving health professionals' engagement by enhancing their skill set, and facilitating timely access to treatment at the right time, with the right person, in the right place. And finally, it also contributes to the Sláintecare vision of reducing the need for patients to get to paediatric tertiary sites for outpatient appointments. Joining me this afternoon are Dr. Grace O'Malley, Star Research Lecturer and Principal Investigator, Obesity Research and Care Group with the Royal College of Surgeons in Ireland, and Professor Clodagh O'Gorman, Foundation Chair and Professor of Paediatrics, School of Medicine, University of Limerick, and Consultant Paediatrician at University Hospital Limerick. Women, you are very welcome. Thank you so much for joining us today. The project, from my reading of it, is essentially about education and training and learning initiative for health professionals to provide better care and service to the patients. Can I come to you, Dr. O'Malley? What is the background to the project? What problem did you set out to solve?
Thanks, Grania. Yeah, we know at the moment that about 1 in 4 children in Ireland have overweight or obesity. And from the WHO COSI study, which is run out of ECD, we know that about 1.8% of children will have severe obesity. So if we look at that at a population level, it's about 18,000 children with severe obesity and about 80,000 children with classified as maybe having obesity. And as you mentioned, these children will have a higher risk of adult disease, so stroke, cardiovascular disease, type 2 diabetes, about 11 different cancers. So in the future, we know they have higher risks. But also more importantly to the family and the child, during their childhood, they will have greater risk of a myriad of conditions. Because fat tissue is stored so effectively in the body, we can store it everywhere, basically. So it means that every system in the body can be affected, or every part of the body can be affected by having an excess amount of fat tissue. So these children will often be coming to health services anyway. But the problem really that we saw was that for most health professionals at undergraduate level and postgraduate level, they receive no training in obesity, even though it's been a focus of health policy since 2005, but also internationally. We see this all over the world. The curricula haven't caught up basically with the reality of the conditions we see now today. So we wanted to provide access, first of all, to training, and we wanted to ensure that health professionals could increase their knowledge. And then we want to think about, well, how can we improve their skills and competence so that when children around the country can access somebody who actually can help them and support them. And particularly when we think about the effect of inequality and disadvantage. So children in disadvantage will have double the risk of developing obesity. So we really have to ensure that when they do look for help, that it's the right help and that it's respectful and sensitive, because often there's a huge amount of stigma in this area as well, and families can feel basically
blamed.
Judged and blamed. Yeah.
Very, very interesting. And Professor Gorman, if I can come to you, were there priority stakeholder groups then that you were trying to reach in order to, further support these patients, but also really develop the skills of professionals? Who were the priority stakeholder groups that you targeted?
That's a great question. And just before I start, thank you for inviting us to talk today. It's great to have this opportunity. The stakeholder groups, there are so many, and that was one of the real challenges of this, but it was also one of the real opportunities to try to contact or have input from as many people as possible. And I suppose if you think about the lifespan of a child with obesity, they go from being a young child to an older child again into adolescence, and then into adult care. And so during that process, there are many, many individuals that they meet across their life. And just focusing in on the healthcare professionals that they meet or should meet, there is a wide range. It's a real multidisciplinary problem, and it should be addressed in a multidisciplinary manner. And that was really our approach to addressing this. And so the various stakeholders have included representatives from all of those different health professionals who might or could or should be in contact with those children. So for example, that include colleagues from medicine in general practice, in pediatrics, in adolescent care, in perhaps orthopedic surgery. So lots and lots of representation there. In the community, colleagues from medicine in public health nursing, community dietitians, community physiotherapists. In medicine again, subspecialists maybe who practice endocrinology and therefore see more children with weight issues. Colleagues with psychology because of the impact of this condition on children's functioning potentially. Colleagues from research, it's a really important group of stakeholders also. And probably one of the key groups was the patient representatives themselves.
I was just going to ask you about that.
Yeah. And whether I say them last and tell you they were the most important, or say it first and tell you they were still one of the most important. Their voices throughout this project, it has continuously impressed me how much importance everybody placed on their voices and how well they articulated their own needs or reflected back on what their needs may have been as children. And so that really informed this process as well.
So you had this co-design process essentially then going on.
Yeah, it was very strongly co-designed with great input from people themselves, either parents of young people with issues, adults with weight issues, or who had been living with obesity themselves when they were children. So even within the parent within the patient representative, there was a lot of different representations in there, which was very powerful, I think. And then, of course, once the training was launched, we then had to reach out to various individuals from the professional groups that represented those professionals as well, to speak about this as a training opportunity.
And get their buy-in to take it on board, deliver it. Yeah.
And get their buy-in to take it on board.
Exactly.
And I suppose one of the things maybe we're hoping is that their buy-in will be easier, because as Grace alluded to, there are deficits in curricula internationally, and we're not actually pointing out a deficit. We're saying, well, here's an opportunity for you to explore something that might support you in that deficit. So.
And just before we leave that issue, what about challenges? I mean, did you encounter challenges with, you know, either accessing various stakeholder groups or resistances, people saying, Mother of God, I've enough on my plate already without taking this on? Or the opposite, did you find people were really open to a well-planned modular curriculum that they could take on and run with? What kind of challenges did you face?
There were many challenges. In fact, there were so many challenges that I think we had to pivot and call them opportunities instead of challenges.
Excellent.
But actually, the one that you cited there, it wasn't the people. The people were extraordinarily supportive from all the disciplines that we've talked about, and any that I've neglected to mention, and that's my fault if I have neglected to mention somebody who had a great contribution. But look, one of the clear challenges was COVID-19 and trying to make this a priority for people during the COVID-19 pandemic. But still, it was very reassuring to us how much importance people still did place on it, even with the time that was limited to everybody because of all these COVID-19 issues that needed to be dealt with.
Yeah, sure. Great. And just to go back maybe to yourself, Dr. Malley, how overall has it been going? And have you any outputs or outcomes to share with us today?
Yeah, so we had hoped that we would initially would train 40 health professionals in person at our International and European Obesity Conference, which was due in May 2020. And then obviously that had to be pushed back to September 2020. And then eventually it was actually delivered as an online congress. But because of it was online, we were able to invite 216 health professionals. So that was for child obesity specific workshops. So that was our first aim. And then our second aim was, well, could we increase access to training by 30%? That was what we were hoping to. Can we increase access for people? And when we started launching our course, we found that about 95% of users had no access to training over the last 2 years. So by delivering that training, we actually increased that by 3,000%, which was wonderful. We hoped to train 78 professionals online. And we've had 961 register.
Wow.
And we've had 513 people trained to date. So we've delivered at least 1 hour of training to 513 people. And then of that, there's another subsection who are going on to do advanced training. And then the other thing we hope to do is increase their knowledge. So the people who actually took the course, we want to see, did their self-assessed knowledge relating to childhood obesity, could we increase that by 30%? And we've been able to achieve that and exceed it, so that we've actually seen an increase in more than 100% of their knowledge, of their self-assessed knowledge. And then the final thing that we really wanted to do, because this isn't just a kind of a one-time thing, this is like our plan for the next 40 years, more or less. We wanted to create a community of practice, because working in this area is very hard. You're really at the nexus of how society, the economy, healthcare, biology, where it all meets. And that means you come up against all of these factors that are obesogenic in our society. So it can be a difficult area to work in. And it really becomes important that health professionals have support from colleagues and mentorship. So we hoped to get 20 health professionals to join a community of practice, and we've had over 500 sign up to that. So that's brilliant.
Wow.
We couldn't really deliver the in-person skills-based training. So that's something that we need to think about for the future. But overall, we've really met all our targets, which is fantastic.
And surpassed most of them with those tremendous figures that you've just shared. So maybe going back to Professor Gorman, what are the service users? So whether that's the professionals, but also I'm interested in the patients. What are people saying to you? Is this something you're hearing feedback on, that it's working, it's good, let's keep going?
Again, it's a great question, but I think Grace has probably largely answered it, because she's told you how many stakeholders have joined in as opposed to those that we had aimed for in the first instance.
Right.
Look, formal and informal feedback has thankfully been excellent. Users have provided us with very valuable information as well on feedback on how to make it better for the future too. So that's very exciting.
Very good.
To think about potential future iterations of it.
And on to that then, maybe back to you, Dr. Malley. What's next for the project? What's your hopes?
Well, we're really lucky that we have secured another year of funding from the HSE for 2022.
Great.
So that's fantastic.
Congratulations.
So we'll be able to keep it going for another 12 months. And we really need to now move beyond, I suppose, knowledge into skills and competencies, because, you know, the theory is one thing, being able to apply it is a very different thing in your local context and with the patients and clients that you see. So we'll hope now to really build on those skills. In particular, one of the things that in feedback that was very clear was that users and health professionals really wanted communication skills training, and what to say, what language to say, how do I do this respectfully and sensitively, because most people, unfortunately, like stigma is rife in this area, but most health professionals, the vast majority, really have good intentions and they're trying to do their best, but it's sometimes a little bit tricky. So we've thankfully secured additional funding as well to run a project on communication skills training. So we'll develop a tool, a training kit for that. And that's just started as well in RCSI, which is fantastic. So that'll be really useful. We'll blend that into the training. And then we need to think about as well, when people have completed the training, can they come to paediatric centres and do clinical skills, so technical skills training around, you know, measurement or different assessment techniques that they'll need, or treatment techniques. So that would be something for the future we'll need to look at also.
Great, fantastic. Look, thank you so much, both of you, Dr. Grace O'Malley and Professor Claude O'Gorman, for joining us this afternoon. I mean, it's such a worthwhile and interesting piece of work, and, you know, for all of the children and adolescents that you work with. Thank you so much for your efforts.
Thank you, Grania.
Best of luck with the project for the future. Thank you.
Thanks, Grania.
So the user reviews there, I think, giving us great insight into the success of the training initiative, which is improving services, the quality of those services, the confidence of professionals working with children who have childhood or adolescent obesity, and really, I think, making a difference to the lives of those children and adolescents and to their families ultimately. So yeah, really interesting and great to hear the follow-on plans and indeed the follow-up funding that they've received from the HSE. So well done to everyone there. Our final project for you today is a community-based pulmonary rehabilitation programme, which is being delivered in Community Healthcare East. Two members of the team spoke with me earlier about their work in this Sláintecare Integrated Funds project. Pulmonary rehabilitation programme in Community Healthcare East aims to deliver a structured pulmonary rehab programme in a community setting to those diagnosed with respiratory conditions such as COPD or asthma. The project delivers an 8-week pulmonary rehab programme. It aims to empower individuals living with symptoms of such conditions to better manage their condition daily. Research has shown that patients who complete pulmonary rehabilitation have a better quality of life, understand their condition better, and therefore are able to manage their conditions more effectively. To hear about this innovative project, I'm delighted to be joined by Mary Going, Self-Management Support Coordinator for Long-Term Health Conditions in Community Healthcare East, and Muthu Krishnamurthy, Senior Physiotherapist with HSE. Good afternoon to you, and thank you both for joining us.
Good afternoon, Grania.
Good afternoon, Grania. We're delighted to be here today as it was World COPD Day yesterday, so we're particularly delighted to be here to
very good.
tell you
So
about our project
very
today.
timely, very timely. Mary, can I come to you first? Tell us a little bit about the background to the project. What problem had you identified, and what is it that the project sets out to solve?
So I'm, as you mentioned, the Self-Management Support Coordinator in Community Healthcare East. And one of the tasks that I had to complete was to map the services and supports for people living with long-term health conditions, including COPD, in the Community Healthcare East area. And as pulmonary rehab is a key evidence-based component of national and international guidelines in the management of COPD, obviously this was one programme that I wanted to map. And as I mapped it, I realised there was no pulmonary rehab in the Wicklow area for patients living with COPD and asthma. So nationally, there's a considerable lack of pulmonary rehab provision in Ireland. We're only meeting 11% of the capacity for patients following an admission to hospital with an acute exacerbation of COPD. So I set out to address the gap, and when the Sláintecare funding came along, I applied for it and we were successful, and we delivered the programme in conjunction with primary care. It's a programme for patients. They attend an 8-week programme twice a week where they learn, they increase their physical fitness through exercise, and they learn how to manage their condition through a series of educational talks.
Very good. And were there any challenges in developing and delivering the programme for you, Mary?
Well, there were a lot of challenges. The first challenge was the recruitment of the physios for the project team and the backfill issues that we had with that. COVID-19 obviously was a huge challenge for us. It was the biggest challenge. The programme initially was intended to be face-to-face, but we had to adapt it to online delivery, and we followed the National Clinical Programme for Respiratory Guidelines and Public Health Advice when we were doing that. Then identifying a suitable platform to deliver the programme on, the network connectivity issues in Wicklow, broadband issues, digital literacy issues with patients, a lack of devices amongst patients, but we had actually foreseen that could be a problem, and we had purchased a number of iPads that patients could use when they were taking part in the programme. Another problem then actually became recruitment of participants. So even though we had a waiting list of participants, when they were contacted, many of them declined to take part, saying that they'd wait for face-to-face programs to resume, because they were fearful of taking part in an online program. Others then were fearful of attending the Wicklow Primary Care Centre, where they had to attend as part of the assessment. While the programme was online, the pre and post assessments took place in person. GPs then had no access to spirometry, and that was a prerequisite for attending the programme. So while that spirometry was suspended, they couldn't refer any new patients to the programme. In addition, in January, February, when COVID was at its worst, the GPs were so consumed with managing COVID and then later on the vaccinations that they didn't have time to make referrals. Right. And then later on, the biggest issue then became the cyber attack. We were in the middle of a programme when the cyber attack hit, and the programme was suspended for 3 weeks until we got permission to continue. But it actually disrupted the flow of the programme, and a number of patients didn't engage or had other programmes or appointments to attend.
Very good. So over to you, Muthu. Would you tell us a little bit about the service users? I mean, Mary has spoken about some initial maybe resistance, a bit nervous, and then COVID making people, perhaps quite rightly, even more nervous. Sure. What are they saying to you, though, the people that you've delivered this programme to? What benefits are they reporting to you?
Sure, Grania. Before I get on that part, could I take a brief moment in conveying my gratitude and thanks to the Department of Health, Sláintecare, the organizers of this webinar, timing it in line with the World COPD Day, and definitely my pulmonary rehab team for giving me the opportunity to reflect on our Sláintecare project. Yeah, so as Mary rightly pointed out, we went through a lot of challenges, but we overcame most, if not all of them. We got 3 programs running between October of 2020 to July 2021. We had them in 6 groups in total, and we had 32 people enrolled for the program, considering all the setbacks we had with COVID. And you know what, everything we went through there. But it was promising that out of those 32, we had 23 of those participants completing 12 out of 16 sessions, and 4 of them did all the 16 programs, which is very reassuring. With regards to the feedback, what we did was we used what we call as a patient experience questionnaire. So after the program, we asked them to send this, and that was done confidentially. And we collected, we identified a theme. So the words most of them described would be helpful, informative, motivational, improving on energy levels, improved confidence, peer support, and one thing everybody commented that they wished the program continued on.
Very good, very good. And in terms of those numbers, I mean, a pretty good completion rate and the number of modules that people are doing. And what about, are you asking GPs for their view on how their patients, and what are they saying?
Yeah, so definitely the GPs locally within the area felt that it was easy for them to refer the participants to us because the service is available locally. And there was a very overwhelming positive response from them. They also commented that they can see the progress in the patients when they go in for a review, that they all demonstrated improved confidence levels and certainly improved quality of life.
That's great. That's great news to hear that from them. So from the patient's point of view, they're getting good outcomes. I mean, confidence is a huge issue, being confident that you're doing the right things to manage such conditions.
Certainly.
The GPs reflecting that in their comments. So,
certainly.
You know, the program as you've delivered it seems to have been successful. What does the program need to make it sustainable in your view?
Right. Obviously, since the project ended in July of this year, we transitioned to the enhanced community care funding, which means then the program is up and running. I'm actually in the middle of my program. I've just done my morning group. I'm now getting ready to do my afternoon group. So the program is continuing on. At the moment, I'm working from Rathdrum Primary Care Centre. Till the end of July, we were doing virtual classes. Now we are back doing face-to-face programs. We hope in the future to do pulmonary rehab programs from different locations within the county. Say it could be available in Wicklow, Arklow, Carnew, depending on the access and the number of people we have from that area. We can actually group them and offer the service as we want it to be in line with the Sláintecare, offering right care at right place at right time. So
very good. Yeah,
we hope to do that.
That's great. And in terms of moving wider than this particular area, are there any thoughts or plans on making this a nationally available program, Muthu?
Yeah, that's a very good question, Grania, because there is going to be what we call as chronic disease management hubs. So we will be based, the hub is going to be based in Bray, and obviously we have hub and spoke model. What it implies is we're going to have spokes, say for instance, at the moment we are in Rathdrum, so the delivery could be in different locations, depending on, as I said, the access and other things that are going to be sorted out in the near future. So chronic disease management hub is in the pipeline, and it'll be available ready sooner to start with.
Very good. And is there any plan beyond Wicklow? I mean, are we talking about this national chronic management plan would possibly be looking to replicate these kinds of initiatives?
Certainly, it's going to be across Ireland, and it's
Excellent.
the HSE plan, not just only for pulmonary rehab, it's going to be for chronic disease management more widely.
Very
yes.
good. Okay, so I guess, in terms of the patients using it, the GPs seeing the benefits, are there any further challenges to the future plans? I mean, Mary mentioned staffing initially was a problem, just backfilling places, getting more of your own physiotherapy professionals on board. Are all of those things overcome? Because I'm wondering, a lot of other people who've developed these kinds of modules, they are continuing with a hybrid. They're both back to doing face-to-face, but they're also continuing online. What's your plan around that?
Yeah, certainly. Now, again, the learning from the virtual exercise classes during COVID can actually be implemented even beyond COVID times. The reason I'm saying is there is going to be a cohort of people with compromised immune system, they may not be able to do face-to-face, or there might be a palliative end of life situation where this is the last resort that they do pulmonary rehab, and they can actually benefit from doing a virtual program. So we are seriously considering doing a hybrid model where the class could be delivered face to face, but people could join remotely online with us. That is definitely the way to go forward, and it actually means we can still offer the service, but it's the right place for them, that they can do it from their own home, and it's the right service, because pulmonary rehab, we know it's overwhelmingly evidence that it does work.
It works. Very good. Thank you very much for joining us this afternoon. Best of luck with the national rollout of what I think has been a very successful initiative. Muthu and Mary, thank you both for joining us this afternoon.
Hello, my name is Mary. I'm 71 years old. Before I started the program, the pulmonary program in Wicklow, Muthu and Mary were the physiotherapists, and online we had to do it, unfortunately, at the time, the way things were. And prior to that, I'm 71 now, as I've already said. Prior to that, I felt about 81. How did I benefit? Mentally, I improved 100%. Psychologically, because things that I had convinced myself I was unable to do, I discovered, yes, I could do them. If I was stiff or sore in the mornings or any time of the day, I'd say, no, Mary, take it easy, you'll aggravate the situation. When in fact, I then learned that by moving, I was loosening things up. Then physically, to get out of the car, get out of the Jeep, I would need assistance. I no longer need that. For example, if I was shopping, I'd be carrying a bag, not a heavy bag of messages, my arm would be sore. With the exercises then, I could now carry a bag of messages. Yes, as far as my chest is concerned, the respiratory problem I had, my inhalers were changed in the clinic in Wicklow, and it improved 100%. I no longer have wheeze, I no longer have problems walking up the stairs, and the education I got was like, yeah, a degree in how my body works and how it should work. And I would advise anybody 100% to do this program, to listen to what you're being told. Don't be scared. It's not forced on you. You're told if it's too much, slow down, and that you can do. But positively educate yourself, and please, it's unbelievable the improvement you will find. Unbelievable. And I have to compliment Muthu and Mary, the physiotherapists. I looked forward every week to going online and meeting them. It was like one big happy family. It wasn't a chore or no, I positively looked forward to it. Yes, please do take my advice and go and seek advice, educate yourself, and do this program.
Thank you to Marie there for that wonderful testimonial. I think I'm delighted to hear the benefits she's experienced from her participation in the programme. And I love her description of the programme being like taking a degree in how her body works, and that deeper understanding of what she needs to do and understanding how the body works. There's no doubt that those with COPD are really enjoying the programme and getting the benefits from it. So you have heard about the work of these 4 initiatives this afternoon. I have a panel drawn from the projects with me now, and we are taking questions, and we have gotten some in already, so do send them in. So our panel discussion then this afternoon, I'm delighted to welcome, rejoin us please, Sue Paffrath, the renal clinical nurse specialist in St. James's Hospital, Irene Maguire from the cystic fibrosis telemedicine team in Galway, Dr. Grace O'Malley from the Royal College of Surgeons, and Professor Claude O'Gorman from the University of Limerick and from University Hospital of Limerick, and also joined by Muthu Krishnamurthy from the Community-Based Pulmonary Rehab Programme that we literally have just heard from there. So you're all very welcome. Thank you so much for joining us. And I think lots of interesting cross similarities between these projects, and maybe we'll talk a little bit about those. Sue, I'll come back to you first, if I could. Would you tell me a little bit more about, you know, working across hospital and community, and some of the challenges around trying to deliver patient-centred integrated care, working across these 2 quite separate spaces, but so important for an integration to do the kind of work you're trying to do?
Yes, thank you, Grania, for giving me the opportunity to be on the panel today. So yeah, initially, one of the rate limiting steps to the development of our service was really simple. It was having a courier to deliver the blood bottles and labels and the urine bottles and whatever else we needed to the CIT headquarters so they could carry out the process, and then getting the bloods and urines back to St. James's to be analysed in the lab. So a very simple solution we found to that was just having a courier basically to bring the bloods and bring them back. So that really was the biggest expense of the project and the only extra resource that we needed. Everything else, there was a lot of goodwill from St. James's renal services here and from the CIT to get the project up and running. So it's worked really well. We've been really happy with how it's transpired, and it fits very well with the HSE integrated model of care for the prevention and management of chronic disease. It provides care to patients in their homes. It's low complexity. It's very responsive, so they're responding on a weekly basis to the needs of our patients. It's managing patients with chronic kidney disease, and it's completely patient-centred. So I think it fits with the model of care for Sláintecare very well. It's also prevented and avoided hospital admission, reducing footfall and allowing us to get through our waiting lists as well, because we can see other patients face-to-face who haven't been seen before to sort of, you know, chip away at our waiting lists. So we really didn't have very many challenges apart from in the beginning, and we've been very lucky. We'd like to see the project continue. We do believe it's sustainable and that it will work beyond COVID. We'd really like to see integration of the project into the chronic disease management hubs, maybe.
Yeah,
that would be something that would be very interesting and very worthwhile. And we'd also like to see the CIT maybe integrated into our St. James's electronic patient record to improve workflow, reduce duplication, any risk of error, anything like that. So there are some of the things that we'd like to see for the future.
Great. And I did think, you know, when you came down to that simple, you know, it wasn't a big technological thing that you need, just let's get the couriers. We've got the experts taking the bloods, taking the urines. We just need to get them to the other experts to get them, and like courier service, you think, great. Just that kind of simple, but nonetheless, it's money. It's another part of the pathway. So I think really successful. Just to move over to Irene for a moment, if I might. And Irene, before I get into some detailed questions that have come in from our viewers this afternoon regarding the project, I understand that you've had some good news since we completed that interview last week. Would you like to share your good news with us?
I certainly would, Grania. We got news last week that our service is going to be mainstreamed. So very exciting times in Galway. We'll be able to continue to deliver CF telehealth services. So a big win for the patients and a really big boost for the team as well. So yeah, delighted to hear that.
Yeah, no, we were thrilled as part of the team here when we heard it, because we were very, very impressed with the work you had shared with us earlier. There's a question has come into you specifically from Ashling, wondering, would it be possible for you to tell us how the €900 saving is calculated? Now, is that too technical a question, or can you try to answer that for Ashling?
Yeah, sure, no problem. We did a readiness assessment before we started the project, and as part of it, because we did want to look at the savings for the patients, because we wanted to look at a very broad range of parameters to show how useful and how beneficial that the project would be. So what we did was we calculated by their mileage from the Automobile Association's cost per mileage. So we calculated the cost per mileage of petrol or diesel, or based on the car engine size, and also how much it costs the patients in parking, and how much on average they would spend in snacks or lunch or whatever when they'd have to, as Stephen mentioned, a 6-hour round trip for some of the patients to attend. So we calculated all of that per visit, and then we've obviously taken note of the number of sessions that have been delivered, so we multiplied that by the cost and then divided it. So that's how we came up to that, and we were astonished that the average saving was €900. And I suppose what's lovely as well, I haven't got the carbon footprint data, but we have actually significantly decreased carbon footprint, so that's very topical at the moment as well.
And long term, very, very important as well, in terms of supporting one set of actions over maybe others that are less carbon positive, let's say. So that's great. I'll come back with some other questions, but just maybe to go over to Dr. O'Malley and Professor O'Gorman, and you're both very welcome again this afternoon. Dr. O'Malley, coming to you first, can you tell me a little more about the multidisciplinary teams involved in your project? And also a question has come in from Rosemary, wondering how different is your training from the Make Every Contact Count training, which I know many people would be aware of. So multidisciplinary teams, and how different is it from Make Every Contact Count?
I suppose I'll start with MEC first, and thanks, Gráinne, for having us here today. So MEC focuses on behaviour change training in adult healthcare, with the focus on tobacco, alcohol use, active living, and healthy eating. So it's, the training is really valuable when you're dealing with adult patients, and particularly when you're thinking about the lifestyle of the patient, regardless of what condition they have. Our training focuses on the specific condition of childhood obesity. So if a child is how to diagnose a child as having obesity, which is the excessive accumulation of fat tissue that causes health complications. So we're not just talking about the size of the child here, and that's important to understand, but also then what kind of clinical assessment the child might need and how you would treat that. So that's the difference between MEC. But it also leads into the other question about multidisciplinary team, because obviously a child will be a baby, there'll be a toddler, there'll be a young child, go into adolescence, and older adolescents, and through each of those stages their body is changing, and that means that many health professionals interact with them through that change, particularly if they have a chronic condition that affects them from a young age. So it may be that they from a young age don't want to get out of the buggy, for example, so they may not want to walk, or they may not reach their motor milestones, so they may be referred to physiotherapy for not actually reaching their developmental stages. They may be still feeding at night, so they may be seen by maybe a dietitian to look at why the child is hungry still at night, or in terms of parenting, feeding practices. They may need to see their pediatrician or an endocrinologist to screen, is there a medical reason or a genetic or syndromic cause for their obesity? And then they may meet with parent training, or psychology, and they may need to be meeting respiratory, dermatology, all of these different specialties in terms of how obesity manifests for a particular child, because fat tissue, adipose tissue is stored everywhere in the body, and that means it affects every part of the body.
So arguably the make every contact count should actually have an element of it, of the recognition of childhood obesity at the earliest possible. So it could be another one of those elements of all the professionals being trained, so that from the earliest stage of contact, you know, the beginnings of childhood obesity can be recognized and can be dealt with. And I'm sure, like many of these other chronic diseases, the earlier the better in terms of working with patients and working with parents. So
yes, MEC is really important. All health professionals should do that training, but it doesn't prepare you to treat an individual condition.
This particular,
so, like lung cancer or something, you're not going to treat lung cancer by doing MEC training. You're
No.
going to use MEC training to facilitate your approach to with patients, but it's not the treatment.
Yeah, no, absolutely. Great stuff. Maybe Professor Gormley, I'll come to you. I'm interested in the challenges in setting up and working with teams. And setting them up is one thing, but keeping them going, I think, is a whole other set of challenges. Anything you want to say about that around, you know, other people listening in, advice around setting up teams, keeping them going, your view on that?
It's challenging, we all know that, but I suppose in something like pediatric obesity, we had been very lucky as part of this project that the people who were part of the project, the stakeholders and participants, had a vested interest in it because it was part of their clinical practice as well. So with that motivation came a huge willingness to contribute and to collaborate, and that was probably key. And then as part of it as well, the types of work that required to be done to the work packages, if you like, in the project could be discipline specifically divided up amongst people as well. So people were allowed to play to their strengths, and everybody who was a part of it wanted to be a part of it. So the collaboration and team working piece was probably easy in that respect, easier than it might be in some
indeed
in some teams.
Yeah, no, great. That's great. Can I come to you, Muthu? As yesterday was World COPD Day, very timely for us to be looking at your project. Can you tell us a little bit more about COPD and how the pulmonary rehab helps people to better manage the condition? Some of the earlier projects were about professionals doing their jobs, maybe in a different or in a more enhanced way. But yours really is about helping the patient to better manage their condition, isn't it?
Sure, yeah. So thanks everyone for obviously being here today. COPD is obviously, it includes chronic bronchitis and emphysema, which characterizes airflow obstruction, which means that there is difficulty with breathing. Pulmonary rehab is obviously the key component of providing best possible care for people with COPD and any long-lasting lung condition. Obviously, it's education with predominantly the exercises. So the expectations is that there is an improvement in exercise capacity, there are symptoms, kind of managing that better, and most importantly, the quality of life. So it was reassuring to hear from one of our participants, the improved confidence, and not just in one domain. You'll see an improvement in all domains of their day-to-day living, and that's so reassuring to work as a healthcare professional to enable that in that cohort of people.
Yeah, very good. And I think that idea of building confidence, and I think we see that in a lot of people who are trying to better manage their own, understanding it. I thought Marie's thing about like doing a degree in my own body, that for so many people it's how does my body work? We didn't all do Leaving Cert biology, so we don't really know how the bits, where they are, and even what they're called sometimes. So I think that's huge. That's part of it. I just wanted to Aisling Muthu had a particular question for you, and she wondered, where does the community pulmonary rehab team refer patients to after they've completed the pulmonary rehab program?
Right. So what we did was we got a representative from the COPD support group in Wicklow Town. Before we completed the program, we invited them to talk about their support group. So they came in, they attended virtually and kind of went through the details. And we got an agreement between us that whoever completed the program with us, they don't need to be reassessed for them to join the COPD support group. So it means that the patients can obviously join directly after they complete the class the same week, so that there is that continuity of the exercise classes.
Very
and
good.
we were able to negotiate that.
It's pretty seamless, which is great for them. I have a comment just come in from Bernadette around the Childhood Obesity Project, and I just have to read it because it's really complimentary and it's great to hear it. Treatment has changed and becoming so much more positive for the children. There are still health professionals that need to be reached out to. It's happening gradually and more services are on the way. So that's obviously one of your pals, Grace and Clodagh, who does feel that things are moving and you're part of that movement. So well done to you. Maybe just some general questions, maybe get some cross conversation going here. We spoke about building multidisciplinary teams to deliver projects, and Clodagh spoke about some of the challenges in doing that. Anyone else who's had to be building these teams? I've asked Sue a little bit about community and hospital. Irene or Muthu, you want to come in on that, the challenge of multidisciplinary teams, building them up and keeping them going? Any comment on that, Irene?
I think we're very fortunate in Galway because, you know, we have a multidisciplinary team that we were working with for years before we actually started our project.
Okay.
Yeah. So we have, and also we would have worked with our clinical engineers over the years as well. So we had very well established relationships. I think one of the things that we saw as an unforeseen benefit really in our project was we've really enhanced the relationship with the adults who use the CF service with ourselves as physios, but also with the whole team, because we're in contact more regularly. So it's become a real early warning system. So with monitoring the patients more regularly, we're actually picking up on more subtle symptom changes, and we're actually implementing treatment earlier, and that experiential learning for the patients themselves, it's worth gold, because as a clinician you can say, we think you should do this, you know, start antibiotics earlier because we think it will help. But when somebody has had that experience, because they're in more regular contact with the team, that experiential learning has been really gold from their self-management point of view. And I know I didn't really answer your question and I snuck in another one, but I just wanted to share that.
That's okay. They call that pivoting, I believe. So well pivoted, Irene. A number of you are involved in using technology, and I suppose the big question around this has been, are there groups that find it easier to engage with technology? I think about my 8-year-old grandson who can, you know, he shows me around my old television, he can get things on the computer that I can't find, and he does it absolutely naturally, as if he was born to do it. So there is something maybe about, you know, older people, resistance, reluctance. And then there is also something that Irene mentioned earlier, and that is the digital poverty, that there are simply people, you know, who, because of where they are, maybe they've no access to Wi-Fi or broadband, have never had to work on a computer. And so just some question maybe about, especially maybe Sue, your use of technology, Irene the same, and Muthu. Have there been learnings and lessons for you in this about use of technology and how to best engage patients in what for some of them might be new technology? Sue, you've had some experience of this?
We're actually developing in renal services a renal app with the HSE for patients, and it's specifically for chronic disease management to empower and help patients manage their condition better and be more engaged with the process. But we found that a lot of elderly patients, if they've any experience with technology, take to it quite well. We thought that they might be limited, but those of them who do have some experience are really happy to have another mode of communication to be able to reach out to you.
Yeah. Yeah,
So,
absolutely. Great. And I know from some of the other projects we've had on, you know, people might start a little bit reluctant, but when they realize they can talk to their grandkids down in Cavan or in Australia, suddenly they're fantastic at getting on to the iPad or whatever. Irene, technology, any comments on that?
Yeah, I suppose that our catchment area, we had to consider what platform we'd use. So we used one that needed the lowest broadband speed to try and ensure the stability. And we've worked with an app as well. So we teamed up with Patient Empower, and we have an app. So the adults with CF actually they can see their own spirometry readings and rate and their SATS monitors. They can see that real time, and we can see that in a portal. But I have to say, I think I learned a lot from our young adults. They're a lot more tech savvy than I ever was.
Yeah, for fact, I think. Yeah, for sure. Yeah. Muthu, technology and engaging people, has it been a challenge for you? Have you gotten over it?
Yeah, so what we did was we made sure that technology and devices shouldn't be an obstacle in delivering the program. So we absolutely did everything to facilitate that. So from day one, we assessed them. We actually got that introduced to them. And we also did what we call as a session zero, which is a day zero. They just join online, get introduced, get the functionalities familiar with. And as everybody commented, it's not surprising, people learned quickly. It wasn't a bother at all. Now, I know network related issues was there, but using the platform wasn't any hurdle at all. Doing the day zero helped us, and we also had the privilege that we can loan out tablets, iPads to our participants. So that wasn't an excuse either. They just have to join.
Okay, and let's turn the lens round. Did you have resistance to the technology from the multidisciplinary teams?
No, not really.
Not for you, okay.
No, we actually, they gave a recorded talk. So I would say the example of dietitian, like we recorded a talk from them. And obviously the psychology team we now work in very close collaboration. So we definitely, there wasn't an issue at all.
Okay, Sue, any resistance there?
I think in the beginning, some of us were, because we didn't feel tech savvy enough to develop an app for our patients.
Good point, yeah.
But we worked with a great company, or we're working with a great company, My Patient Space, and they've really accommodated us very well. No question is stupid. They're very patient and helpful, so it's working out well.
Yeah. And that seems to be a key thing, whether you're delivering online training or whether you're connecting directly to patients, is having a really good relationship with the IT team, so that no question is a stupid question. Every question is helping somebody to understand, and often somebody else's question is the one maybe you haven't had the courage to ask, but it's answering your questions as well. Okay, great responses. Maybe to finish up, I mean, all of you have been developed and delivered successful initiatives for various chronic disease patients and their care during the pandemic. And I'll talk about just the early stages of it, because we're still in it and God knows when it's going to end. But looking back over that period of time, is there one key lesson that you have learnt in your own work about working in pandemic times? Any lesson that personally or in terms of the work, any lesson that you've learnt during the pandemic that you'd like to share with other professionals who might be on the Zoom this afternoon? Grace, a lesson you'd like to share with us?
I think just to keep things safe. So you're not gonna, everyone's tired. People just don't have the same amount of time or ability to contribute that they'd like to. Everyone's stressed. People are, you know, health professionals and our service users are feeling more anxious about attending visits. Everyone's dealing with the residual effects of this, whether they're touched directly by COVID-19 or the restrictions. But the most important thing is safety with our services and to try and keep quality. But really, we have to give ourselves a break as well, because we can't do everything. And we have to just maintain safety and keep our head down, work together, support one another, and keep going.
Very good. Yeah, great advice. Clodagh, a lesson, a learning?
Sorry, I was on mute. It's such an interesting question. I think worldwide, countrywide, in all regions and disciplines, whether we're working in community or in hospitals, everybody has had lots of challenges during the pandemic. And one of the huge ones I had actually relates back to your previous question, was around technology. And it was, what can we safely do using technology? And how much can we replace face-to-face clinical practice with technology? And actually in the universities as well, how much face-to-face teaching can we replace with technology? And I think my experience has been not all of it, but certainly some of it can be done effectively and efficiently and safely using technology. And, you know, I suppose Grace and I work with children, so we have the opposite experience in terms of their keenness and their eagerness to do whatever they can using technology and to make it fun. So child apps work best if they're nearly like games for children to play and to learn through play using technology. And it's a language that our children are speaking so well, and they're going to grow up with that. And I think as healthcare, everybody, we need to respond to that by exploring the opportunities that technology provides, while at the same time recognizing that it can't replace everything that we do. There are clearly times when we can't use technology for clinical skills, and it won't ever, I hope, replace entirely the face-to-face piece, but certainly there's more opportunities for it.
Great, thank you. Muthu, a lesson during COVID you'd like to share with us?
Yep, certainly. So as our team, we felt very satisfied that we were able to support a cohort of people who were cocooning. It was right at the time when we started. So we were able to help them to some extent. And this was their first social interaction after, you know, a number of months. So we were able to facilitate that, and physically we were able to support them too. So that definitely was, you know, was a learning for us.
Very good. Sue, a lesson you'd like to share? Anything you've learned?
I think really it's just reiterated the value of teamwork and how important it is, the multidisciplinary team, everybody listening to one another, trying to accommodate one another, and just ultimately having the one goal of the patient and the outcome for the patient in mind.
Very good, thank you. And Irene, last word to you.
I think just supporting one another through a really difficult time, and providing that support and providing the necessary equipment and the information that people need to be able to deliver their care safely, so that we can stay connected to the people that we're providing a service for in a really challenging time.
Yeah, for sure. Thank you. And to all of you, I would wish you, you know, the value of kindness. I've seen it right throughout pandemic, kindness to ourselves, kindness to others, kindness to the team. And it really does seem to be increasingly important as we all possibly get more frustrated with living in these pandemic times. Can I thank each of our guests today, all of our panelists and those who featured in the videos. Well done to all the great Sláintecare and HSE work as it continues. Today's emphasis on enhancing capacity and skills for the management of chronic conditions is, I think you'll agree, well depicted in the work of our 4 featured initiatives. I want to thank all the team here who helped produce the session: Rosaline Harlan, Muriel Farrell, Kira Eustace, Lindsay Dre, Erica Kinsella, Nicole Keohan, and Tom Dukes. You can watch this webinar back or recommend it to your colleagues. It will be available on the Sláintecare website. So do send us your feedback. We do love to hear from you. And any questions we didn't get a chance to answer will be posted to you in the coming days. So from me, Gráinne Healy, continue to stay safe, wash your hands, hold firm, and be kind to each other. Thanks very much.
Thank you.